So this is where I left off. Um, this is where we left off in the last video. We've already seen breath control variables, pressure and volume. Then we have seen the three breath sequences, CMV, IMV, and CSV. Now, the last thing is the targeting schemes. That also gives us various combinations of various modes that we see. Most basic type of targeting here is the set point targeting. What is the most basic type? Here we are setting exact variables like set pressure or set volume, and ventilator is giving us an output. So is seen in classical default volume control or pressure control modes in the various ventilators. Dual targeting is more sophisticated. Here ventilator switches between pressure and volume goals within the same breath. Not too many modes have this type of targeting schemes. This ensures both pressure limitation and adequate volume delivery. How it is achieved depends upon particular mode. Example of this type of targeting scheme is volume assured pressure support and the volume control with flow adaptation mode active on the Mackay Servo I. Very popular targeting scheme is adaptive targeting, where ventilator automatically adjusts one variable to meet the target of another variable. Examples here is pressure regulated volume control and VC plus mode in on the PB840. Servo targeting. Servo targeting here, breath delivery is continuously adapting to patient effort. So ventilator is giving an output. The inspiratory parameter is output is being directly given in proportion to the patient's effort. So classical example of this is NAVA, neural adjusted ventilatory assistance, and the proportional assist ventilation plus mode and automatic tube compensation if it is activated. This becomes an example of servo targeting because here in proportion to a patient's effort, the output is being provided by the ventilator. Optimal targeting is a sophisticated targeting scheme where Otis equation is used as a mathematical model to minimize the work of breathing. This is used in the adaptive support ventilation mode in Hamilton. Then two other more advanced targeting schemes are biovariable. Ventilator can set the inspiratory pressure or tidal volume randomly to mimic the variability it observes during normal breathing. An intelligent is automatically adjustment of the ventilatory pattern using AI programs like physiologic, artificial neural networks, etc. Examples of this would be IntelliVent ASV, and very rarely used in day-to-day practice. So examples of the modes which use this targeting scheme. Set point basic targeting is used in the volume control, pressure control default. Basic mode in Mackay, Hamilton, VCV, PCV, basic mode. VCPC, VC pipe and Rager, Puritan Bennett. Dual targeting slightly more sophisticated where within the breath output changes. So it is seen in Mackay and volume control with flow adaptation and VAPS on the VAPS on PB840 ventilators. Variable is seen in variable pressure support mode on Dragger. Servo, as we discussed, is patient inspiratory response of the site parameters changing in proportion to the patient's effort is seen in the eddy signal in NAVA, electrical activity of the diaphragm, how much patient is wants, proportional assist ventilation plus in PB, and ATC on Drager if it is activated. And adaptive targeting is seen on PRVC classical. APV, VC plus and autoflow. We'll see how this behave technically and optimal in adaptive support ventilation in Hamilton. So we'll look at some examples to understand how to ultimately give the whole tag to suppose a one ventilator, completely classify one mode. So for completely classifying any mode, we need three things already discussed many times: control, variable, breath sequence, and targeting scheme. Let's look at the very basic mode, that is the volume control assist control mode on PB840. Here we are setting inspiratory volume and flow both are preset. It becomes control variable becomes volume. Every breath will be volume cycled because flow and volume are being tightly controlled. All breaths therefore become mandatory because patient cannot control the timing. So the breath sequence becomes CMV. Spontaneous breaths are not possible. So this is a CMV. And as we have set all the parameters of volume and flow patterns, so targeting scheme becomes the basic targeting scheme set point. So ultimate complete classification of this mode would be, in terms of the tag, would be VC CMVS small s for set point. Now what happens if we switch to a mode as SIMV pressure support with VC plus mode on PB840 itself? Now we are set here for the mandatory breaths, we set tidal volume but not the inspiratory flow. So control variable becomes pressure. Now as the SIMV is also set, so spontaneous breaths are also possible. So sequence will not remain CMV. Now it will become IMV. And for the mandatory breaths, ventilator will adjust the inspiratory pressure for mandatory breaths to achieve a preset tidal volume because we have set it. That is our goal. So targeting for the mandatory breaths here becomes adaptive. And for the other breaths, the synchronized breaths, SIMV breaths, which are will be pressure supported. So synchronized breath will be mandatory, but this pressure spontaneous breath will be pressure supported. So this will become an IMV, and this targeting for the pressure supported breath will be set point. So the complete classification will be PC pressure controlled. Both mandatory spontaneous are pressure controlled, and because spontaneous are we are allowing those allowing spontaneous by using SIMV. So IMV A comma S. So A is for the primary mandatory breaths, that is adaptive. For the other secondary breaths, spontaneous breaths is set point. If we eliminate SIMV and just use the VC plus, that will become, again will remain pressure control. But because there is no intermittent IMV breaths allowed, no spontaneous breaths allowed, all the triggered breaths also will be the same, identical to the by default breaths. So all the triggered breaths will be mandatory breaths. This will be continuous mandatory ventilation, and the targeting will become adaptive. This is PC CMV adaptive. So suppose more examples on CMV continuous mandatory ventilation mode on trigger. This if we have just set the CMV, it acts like a volume assist control mode. It remains a volume control mode with continuous mandatory ventilation with spontaneous set point targeting. If, however, we add autoflow to it, now it changes completely. Now it will start adjusting pressure to reach the set tidal volume target, and inspiration will become time cycled. The whole breath will become a pressure controlled breath. Now it changes to pressure controlled CMV adaptive. That will be the complete classification of CMV mode with autoflow on rider. More interestingly, uh, in Mackay's mode, if you have volume control without flow adaptation, it acts like a conventional volume control mode, where breath control is volume, sequence is mandatory ventilation. All breaths will be flow, time, everything is controlled, cycling is controlled. These are continuous mandatory breaths, and targeting scheme is set point. But when you activate the flow adaptation, then you start getting spontaneous breath become possible, because if the flow target is not met, patient can demand more flow. In that condition, breath will change. That same breath will change to pressure supported breath. It will start with the volume control, but it will change to pressure control. And the patient mechanics, since they are determining the flow and cycling, becomes a spontaneous breath. So we cannot say that it is CMV, because technically now in this type of breaths, flow target is not met. Patient is demanding flow and deciding his own how much flow he wants. He's control over the timing as well and cycling as well. So this becomes a spontaneous breath. So this sequence becomes IMV. So this complete mode becomes VC with IMV with D oblique D or comma D, that is dual targeting for both the mandatory as well as the spontaneous breath, because changing within the breath is possible. The opposite of this is a pressure control mode with machine volume in care fusion area. Here, a similar thing happens, but it starts instead of VC with flow adaptation. Here, it starts with a VC volume control breath. This breath, pressure control with machine volume in care fusion area, starts with the pressure control breath. But if that volume is not met, it will switch to a continuous flow till the whole of the machine volume is delivered. So the main control variable remains volume. Focus remains on volume. So what happens in a simple pressure support mode? Here we just set inspiratory pressure. The control variable is pressure. All breaths, because they are patient triggered and cycled, And so it's a type of flow cycling. So sequence remains a continuous spontaneous ventilation. All the breaths will be spontaneous. Main parameter is set. We have just set a parameter and that output is being given. No ventilator is not adjusting any more inputs. So basically targeting becomes a set point. So the classification for pressure support will be pressure control PC CSV and S, that is set point. Sometimes you may get compound targeting. Suppose in this on the dragger ventilator you have CMV plus autoflow plus tube compensation. Now what will happen is for each breath, because of we have seen CMV alone is like a volume control. When we add CMV plus autoflow, it becomes like a PRVC, where ventilator tries to manage the pressure to get it to target a set tidal volume set. But with tube compensation, in response to the resistance, also there will be output will be changed. Pressure may increase. So for all the mandatory breaths, targeting there are two types of targeting in place. So it will become at adaptive as well as servo. So we classify this mode as PC, CMV, AR without any comma, because all these breaths, mandatory breaths are mandatory, and they are both the schemes are applied on all the breaths. In contrast to a few of SIMV PC with PS, so it will be all sequence will be IMV because you have added SIMV here. The PC, IMV, S, oblique S, first S for primary breaths. Those are also set point because pressure is everything is controlled. And for SIMV pressure supported breaths will also be set point, as we have seen. The pressure support is set point targeting in the last slide. So if you apply tube compensation on spontaneous breaths only, then it will become PC. Those modes becomes PC IMV S oblique R. The second variable is for this will tube compensation is active for second, that are the SIMV breaths, spontaneous breaths. So that will be servo targeting. R denotes servo targeting. And if you apply tube compensation to both mandatory and spontaneous, then it will be SR for both type of breaths. So servo set point, servo for both type of modes. Another type can be a combination of optimal and intelligent targeting in the both type of breaths. It is seen in the IntelliVent ASV, where Otis equation is used for optimal targeting, and intelligent targeting is seen where adjustments of PEEP and FiO2 is done and forces lung protective limits are enforced. So the whole idea of you looking at the tags is that we can know that which modes and various across the ventilators behave similarly. All that may be very very fine differences, but they act like same. So we see CMVS as the classical volume control mode. So assist control, volume control, CMV on Dragar acts like a conventional volume control CMV. Then we see IMV here. We will when we if we add SIMV, this will become a SIMV volume control pressure support. SIMV. This will here now sequence will change to IMV, and set point targeting will applied on both sets of primary and secondary type of breaths. PCCS CMVS is the basic pressure control. Continuous mandatory, all the breaths will be mandatory, and set point targeting. PCCMVA, here comes the adaptive targeting, where the ventilator manages the pressure to reach the tidal volume goal. So VC plus assist control in PV840, CMV with autoflow applied, that is important on Drager, adaptive targeting, adaptive pressure ventilation, pressure regulated volume control. These are all acting similarly. If you add SIMV to this, then it will become here. Let SIMV volume control plus VC plus with pressure support, mandatory minute volume with autoflow. This is a similar SIMV pressure regulated volume control. If you add SIMV PC PS to PRVC, then since you are adding spontaneous breaths by using SIMV, so the additional secondary breath is spontaneous. So sequence as a whole will become IMV, not CMV. So it will remain pressure control IMV A, S. So adaptive for the mandatory breaths and set point, because those spontaneous breaths will be pressure supported, and pressure support is set point targeting. This will be PC IMV A, S. Similarly, totally spontaneous mode like spontaneous CPAP pressure support. These are all PC pressure control. Pressure is being controlled, set. These are all spontaneous breaths. Patient can get as much flow as he wants and terminate on the base of the flow decay, that which depends on the patient's characteristics, compliance. So it's all spontaneous and set point targeting because the basic set pressure is set. This is how we, if we know the tags, then we know which modes across the brands act similarly, and we avoid confusion. And so, in a case of Mackay, we know that this volume control mode is not that simple. It changes completely the targeting scheme, whether your flow adaptation is active or not. Now, we'll just do some in the end. That is the whole purpose actually of using this taxonomy, is that we avoid confusing terms and use standardized terms. Clear differentiation between spontaneous breath, mandatory breath, and the type of breath sequence and the targeting scheme that is used in one particular ventilator. So that we can demystify the long set of names that are various modes. The innumerable number of modes are there, and the brands keep coming up with various modes, fancy modes. But in technicality, more of them remain the same. So we should know how exactly is breath being delivered in these modes. So first is question that we see is, let's see which of the following is not one of the three defining attributes of the taxonomy. Control variable sequence targeting scheme. So trigger sensitivity is not the attribute for defining the mode. So in this taxonomy, breaths are classified primarily based on what? So presence or efficient effect, that is trigger source, not necessarily who controls timing and size. So that is the defining factor. So what controls the timing and size of the breath? That is the primary variable. Which statement about mandatory breaths is correct? Mandatory breaths are always patient triggered. Mandatory breaths can never be patient triggered. That is not possible, not correct. Mandatory breaths are defined by guaranteed delivery. So this is the correct thing, because in mandatory breaths, the inspiratory parameters ventilator will ensure that those are met during the inspiration. Breath is classified as spontaneous if patient triggers. Not necessarily, because if patient triggers in the synchronization window or patient triggers in a pressure assist control, that will give rise to a mandatory breath, not a spontaneous breath. Pressure varies during inspiration. Now, patient determines both breath timing and size. So this is how a breath will be classified as spontaneous. Inspiratory flow is variable. It can be variable in pressure control CMV, so it is not spontaneous breath. Only spontaneous breath is like a pressure support mode, CPAP with demand valve, or PSV. Those are classic spontaneous modes, as we have seen the examples of this in the previous video. Which breath sequence includes both mandatory spontaneous? So IMV. These modes are all. PSV is totally spontaneous. CSV is spontaneous. CMV does not allow spontaneous breaths. IMV is combination of both. In VC CMV, the patient triggered breath is spontaneous assisted, mandatory, and supported. So because it is CMV, though by definition no spontaneous breath is allowed. It is all mandatory breaths. Patient may trigger, but those will be mandatory breaths. Why does Chadburn reject the term assist control? It is clinically obsolete? Maybe, but it's not, because assist defines the trigger. It confuses triggering with breath type. This is the most important thing. Assist basically means patient has maybe required assistance, wanted assistance by triggering, but that does not define the breath type. It ignores pressure limitation, cannot be applied to SIV, can be applied, but confuse triggering with breath type. That is the main issue with this term. A mode which maintains preset tidal volume by adjusting inspiratory pressure over successive breaths uses which targeting scheme? We have seen many examples. Classical modes, these are adaptive targeting. Examples are PRVC, VC plus, CMV plus autoflow. Then which targeting scheme allows within the breath adjustment of one variable while targeting another? It is the dual targeting scheme seen in the VC with flow adaptation on the Mackay. In volume control with flow adaptations, ROI, VC, autoflow TOW, the targeting scheme is best described as just discussed. I should have omitted this one, is dual targeting. Which mode is classical example of servo targeting? PSV, PAV, and NAVA SV. So PAV plus is also a type of servo targeting, but NAVA is classical example of servo targeting. Why is VC CSV, volume control CSV, not possible Impossible in taxonomy because volume cannot be controlled during spontaneous breathing. Cycling by volume requires mandatory bed termination. This is the technical reason, because volume by itself is controlled. Patient cannot demand more volume or more flows if he wants. So it cannot be a CSV spontaneous breath. If any part of this timing, size, or cycling becomes controlled, goes out of control of the patient, it becomes mandatory breath by definition. So this becomes a VCCMV or VCIMV. Which statement about triggering is true? Triggering defines whether a breath is mandatory, spontaneous. No. Triggering determines control variable. Triggering is dependable breath type. Triggering is part of targeting. So probably triggering is independent of breath type. That we need to understand. Triggering does not define whether the breath is mandatory or spontaneous. A triggered breath may be mandatory. The primary goal, ultimately, the last slide is also, we want to replace confusion, but ultimate goal is to create a universal logical classification of modes here, so that we know there's no ambiguity in how the modes are in various between ventilators and how you use it on day-to-day basis. Thanks for watching. I hope it was useful. I might have made some technical mistakes in term description of some modes here. Thanks.